I first noticed a swelling on the left side of my neck. Then after 2 days, the swelling became larger. My swelling became harder, so it became a hardened lump. Then after 7 days, I just noticed that I noticed it growing. As soon as my GP examined it, he knew there was something wrong. I had my blood test, urine test, and then had needle biopsy. And then we went to a PET CT scan. Then we went from there to tissue biopsy. And from that tissue biopsy, I went home, went to the ER because because the swelling became even larger from a golf ball when I first started to a softball. And went to the ER, and that's when I met Sean.
I first met Morihu in the emergency department in Christchurch Hospital. He was lying on a trolley in the middle of the department. He was surrounded by doctors and nurses. He looked absolutely terrified. He had this great big horrible lump in his neck. Now the reason I was down there was because they'd performed a biopsy 4 days previously, and we had some provisional results on the biopsy. It looked like it was going to be some kind of lymphoma. The reason he'd actually attended a bit earlier than planned was because the lump had got bigger really quite quickly after the biopsy, and we were worried about his airway, and we were worried about his internal jugular vein. We didn't want that to get clotted off. There was a lot of pressure being exerted on these structures. So it was no wonder he looked terrified. We admitted him directly to the haematology ward, and because we knew we were going to get a little bit of extra information and we had a good enough biopsy, we could afford to get him started on some treatment before the definitive chemotherapy. So we started him on some steroids. We know that steroids will shrink down these lumps very quickly, and we also started him on some blood thinning medication to prevent him from clotting off his internal jugular. So once we were happy that Morihu's airway was not compromised and that he was established on steroids, he was doing fine, we actually let him go home because we didn't have the definitive diagnosis from the biopsy at that point. We also didn't know the extent of the disease, so in order to establish that, we performed a CT scan of the neck, chest, abdomen and pelvis. We looked at the bone marrow to make sure there wasn't any evidence of lymphoma there. Fortunately, there wasn't. So by the time he came back to us, we knew that we were dealing with diffuse large B-cell lymphoma, which was localized to the neck. So what is lymphoma? Well, lymphoma is a form of cancer arising from the lymph nodes or other lymphoid tissue. So you've got lymph glands in your neck, under your arms or in the groin, so it might be swelling that you can actually see or feel. You've also got lymph glands within the abdomen and mediastinum, and you can't see those unless you use a CT scanner, so they can get quite big before they're noticed. Other lymphoid tissue would include the tonsils and the spleen. There are heaps of different kinds of lymphoma. There's over 80, in fact. This fella is Thomas Hodgkin, and he first described his version of lymphoma in 1832. There are actually only 5 subtypes of Hodgkin's lymphoma. All the rest are non-Hodgkin's lymphoma, and we won't talk about all of those because there's just far too many. What we will talk about, we'll concentrate on the common ones. So we've got diffuse large B-cell lymphoma, which you'll remember was what Morihu had. And that's the most common form of high-grade lymphoma that we see. Follicular lymphoma is the most common low-grade lymphoma that we see, and it's quite useful to compare those two because they behave quite differently. So how does a patient present if they've got lymphoma? Well, typically they will get painless swelling of the lymph glands, and that might produce a cosmetic effect. You see a lump where there shouldn't be one. Or it might be that the lump presses on adjacent structures and causes symptoms because of that. The other thing we sometimes see, especially if you've got high-grade or bulky disease, is that the patients will develop constitutional symptoms. We call these B symptoms, and that includes things like unexplained weight loss, night sweats, and fevers. There are some symptoms that are peculiar to Hodgkin's disease, and these include alcohol-induced pain in the lymph nodes and generalized intense itch. With Hodgkin's disease, one of the points of difference is the age of the patient. The median age at presentation is 29, so that's different from the other forms of lymphoma. The tumours tend to be slow growing, but they present with localized disease, and usually that might be a lump in the neck, for example. When they do spread, the spread is contiguous. You're certainly not going to see random lumps popping up in the groin without anything in between. And this is one of the things that distinguishes Hodgkin's disease from non-Hodgkin's lymphoma. The pattern of lymphadenopathy can give you a clue as to what type of disease you're dealing with. With high-grade disease, the tumours grow very rapidly, they've been noticed quickly by the patient, and they're likely to present with localised disease. With low-grade lymphoma, like follicular lymphoma, it's a lot slower, and the patient might not notice that these lymph nodes are growing until they're really quite widespread and bulky. So they typically will present with widespread disease and often with bone marrow involvement. So if you suspect lymphoma in a patient, the only way of being sure about the diagnosis is to perform a biopsy. But before you subject your patient to an invasive procedure like that, it's worth thinking about the other potential causes of lymphadenopathy. They're much more common. Infection, for example, will cause generalized lymphadenopathy in some cases. For example, glandular fever, Epstein-Barr virus. You can test for that. You can get localized lymphadenopathy if you've got an upper respiratory tract infection. Sore throat, swollen glands, very, very common. If you're sure you've ruled out all the other potential causes, then sure, go ahead with a biopsy. So here we're looking at follicular lymphoma. Follicular lymphoma is derived from slightly more mature lymphoid cells. So when they form a tumour in a lymph node, you actually get follicles forming. It looks almost like a normal lymph node, but these follicles are full of lymphoma cells. If the bone marrow is involved, again we see follicles because of the nature of the lymphoma. If the marrow is involved, it's not surprising that you sometimes see leukemic spillover into the bloodstream, and we can see these small, mature-looking lymphocytes with a characteristic cleaved nucleus. I think they look like coffee beans. So now we're looking at an example of diffuse large B-cell lymphoma. This is what Moruhu had going on in his neck. And you can see there's no semblance of normality to the architecture here. These are big, nasty, immature cells that do not play by the rules. This is an aggressive lymphoma. It doesn't form follicles, it forms diffuse sheets of lymphoma. If the bone marrow is involved, you see exactly the same pattern, and if you get leukemic spillover into the bloodstream, you can see that these cells are large, very nasty looking and aggressive. They've got open chromatin, they've got multiple nucleoli. They're bad news. So we've just looked at examples of lymphoma histology here, but when you remember that there are over 80 different subtypes, you can appreciate that, well, it's not always that clear cut, and you really do need an excellent histopathologist to help you through. They sometimes have to resort to additional techniques such as immunohistochemistry, and that looks at the protein expression profile of the lymphoma cells. And sometimes they use molecular techniques such as FISH, which they can use to look for specific mutations. What you do need to have an appreciation of is the basic differences. So we can divide non-Hodgkin's lymphoma up into B-cell and T-cell lymphomas, and that's important because the treatment is slightly different. And then it's important to distinguish between high-grade lymphoma, of which diffuse large B-cell lymphoma is the most common, and low-grade lymphoma, of which follicular lymphoma is the classic example. Okay, so I'm going to say a little bit about staging in lymphoma. That is, how widespread is the disease. The more widespread the disease, the higher the stage, the worse the prognosis. And in those cases, you need to be a little bit more aggressive with your treatment. In stage 1 disease, only one group of lymph nodes would be involved. For stage 2 disease, it would be 2 separate groups of nodes, but they have to be on the same side of the diaphragm, so maybe the neck and the mediastinum. For stage 3 disease, you have to have lymph node involvement on both sides of the diaphragm, so say neck, mediastinum, groin. Stage 4 disease, you get extranodal involvement, so that might involve, say, the liver or the bone marrow. We can further define a patient's stage depending on whether or not they have constitutional symptoms, so things like unexplained weight loss, night sweats, fevers. Say you've got a patient with stage 3 disease and they have these symptoms, then we would call them stage 3B. Patient's stage impacts on their overall outcome. We know that advanced stage disease is not so good as having localized disease. But that's just one factor that influences their outcome, and we can combine their stage with other factors using a prognostic scoring system. When we did this in Morohu's case, we were happy to realize that he only scored 1 point, and that was for being over the age of 40. He scored nothing for any of the other risk factors. That translated into an excellent predicted 5-year survival of 96%. Other types of lymphoma have their own scoring systems. Choice of treatment for lymphoma depends very much on the subtype, particularly whether it's high grade or low grade. High grade lymphoma will progress rapidly if left untreated. Upside is that these cells, because they're proliferating so rapidly, they're exquisitely sensitive to chemotherapy. And we can actually cure many types of high-grade lymphoma as a result. Low-grade lymphoma, in contrast, progresses less rapidly, so we can afford to defer treatment until it is absolutely necessary. And that's important because the treatment itself can be quite toxic. So we treat low-grade lymphoma if it's at a more advanced stage or if it's causing symptoms or complications. We tend to see a reasonable response to treatment, but because these cells are proliferating less rapidly, they're inherently more resistant to chemotherapy. So although we see a response, the disease will typically relapse, and it runs a fairly indolent relapsing remitting course. So how do we decide on the optimal treatment? Well, we discuss each case individually with the multidisciplinary team. If the disease is localized, then we can get away with less courses of chemotherapy, and that's good because it's less toxic to the patient. In Morohu's case, we gave 3 courses of a regimen called R-CHOP, and we combined that with directed treatment, involved field radiotherapy to the cells in his neck. Now, simply poisoning your patient and expecting them to recover better than their disease doesn't seem like a very clever strategy. Ideally, we would have a treatment that only targeted the disease and left the patient alone. We're not quite there yet, but recently we've managed to produce some better targeted therapies, and one good example of that is the monoclonal antibody rituximab. Rituximab is the R in R-CHOP. It's not chemotherapy, so it doesn't have the same nasty side effects. It's a biological agent, a monoclonal antibody that we have manufactured to specifically target the CD20 protein, which is expressed on the B lymphoma cells. It's given as an intravenous infusion, it binds to the lymphoma cells, and it kills them. Rituximab was first introduced about 20 years ago, and it has made a huge difference to survival.